So I'm Sarah Adams. I'm a GYN oncologist at the University of New Mexico, and I've worked with the group at the Ovarian Cancer Research Alliance for many years. I'm really happy to be here today. Since I'm in New Mexico, there'll be pictures of New Mexico through my slide set because it's a beautiful place and it's a nice opportunity to look at the mountains as we're going through this. As far as disclosures go, I do receive clinical trial support from AstraZeneca. As I mentioned, I have collaborated with the Ovarian Cancer Research Alliance, most recently as a scientific advisor. And this is where I've received research support in the past years. Here's the plan for today. I am going to talk about recurrent ovarian cancer and the likelihood of recurrence, the ways that we diagnose recurrent ovarian cancer, and then some options for treatment. And then I'll talk a little bit at the end about clinical trials and some factors that you might consider if you're thinking about enrolling in a clinical trial. If I'm talking too fast, if you can't hear me, or if there's any issues, please put it in the chat. The caveat is that it's hard for me to watch the chat and talk at the same time. So if I'm not making sense, just let me know. And I do just want to say that I know this is a hard topic. And so I'm happy to take questions. I'll do my best to pause and take questions as we go, and then I'll answer questions again at the end of the session. Please just put your questions in the chat as they come up, and we'll go through them as best we can. Okay. So just to frame the information we'll be talking about, I think it's worth remembering that ovarian cancer includes several subtypes of cancer. The ovary is made up of a couple of different kinds of cells, but the most common type of ovarian cancer is epithelial ovarian cancer, which comes from the outer lining of the ovary, and now we recognize probably comes from the tube and lands on the ovary. And since those are the most common sources of this cancer and the most common type of disease, most of the information I'll be sharing with you will be clinical trials that are testing treatments for epithelial ovarian cancer, but I'm happy to talk about less common subtypes as they come up, or if anybody has specific questions. And those include germ cell cancers and some stromal cell cancers, like a granulosa cell tumor. And then, as you probably know, there's different subtypes of epithelial cancer. And again, the most common type is a serous ovarian cancer. And since that's so much more common than the other subtypes, again, most of the clinical trial information that we have is derived from groups of people who have serous cancers. The other kinds of epithelial cancers that are less common are endometrioid, clear cell, or mucinous tumors. And we can talk about those as well if people have specific questions. So when we talk about ovarian cancer, we often talk about initial treatment as our best opportunity to achieve a cure. And so initial treatment for ovarian cancer is quite aggressive, using a combination of chemotherapy and surgery. Sometimes people have surgery first and then chemotherapy, and sometimes they have chemotherapy prior to surgery, which is called neoadjuvant chemotherapy. But the goal is to get rid of every tumor implant that we can safely remove through the combination of these two approaches to treatment. And then oftentimes, more often now than previously, people start what's called maintenance therapy, which is ongoing treatment with sometimes a drug called Avastin. The other name of that is bevacizumab, and we'll talk about that more later. Or these days, a PARP inhibitor, which is an oral agent, to try to prevent recurrence or delay the time until cancer recurs. Once ovarian cancer is diagnosed, we tend to keep track of people very closely. And so if they're not actively being treated with maintenance therapy, we'll continue to surveil them with ongoing physical exams and often tumor marker labs every 3 months, and then sometimes every 6 months. And if things are going well, those visits get spaced out further. But what we'll talk about today is recurrent ovarian cancer. And so I'll start just by talking about the likelihood of recurrence and some of the data that we have available about how often we see recurrent disease. This is an old figure, but unfortunately it still applies today, demonstrating that the majority of people who are diagnosed with ovarian cancer will at some point have a cancer recurrence. And the likelihood of recurrence goes up with the stage at which, the stage of disease when someone's diagnosed. Most people with ovarian cancer are diagnosed with stage 3 or stage 4 disease. And you can see that most people with stage 3 or stage 4 disease do experience recurrence at some point. Sometimes those recurrences can happen after a few months. Sometimes those recurrences happen after years. And sometimes people have very long treatment-free intervals before recurrence is diagnosed. But we watch very closely for recurrence in patients with ovarian cancer because we know that there's a high risk that the disease will come back at some point. And we hope that catching it early will allow us to consider alternate treatment options before the recurrence becomes symptomatic, to preserve someone's quality of life and to keep the most treatment options open for that particular person. And so the way that we watch for recurrence is to ask you about symptoms and to do imaging studies and to follow tumor markers. And symptoms that are associated with recurrence are very similar to the symptoms that might be associated with initial diagnosis. And maybe you know that this approach to screening has failed to help us find ovarian cancer early at initial diagnosis, but it is helpful for tracking someone who has a diagnosis of ovarian cancer to look for evidence of recurrence. And so the symptoms that we ask patients about are bloating or abdominal fullness, any new pain, changes in bowel or bladder habits, any new discharge or vaginal bleeding, leg swelling that might suggest upstream obstruction of venous return, shortness of breath or new pulmonary symptoms, and nausea and vomiting. But really what we tell people is if they have any new symptom that seems persistent, to please let us know. So we can bring them in sooner and decide whether it might be associated with their cancer diagnosis. And then once somebody has symptoms or when she's coming in for routine surveillance visits, the kinds of tests that we do to look for evidence of recurrence are physical exam, and we often subject people to pelvic exams as part of surveillance because that gives us an opportunity to assess the pelvis, an area where we often can feel cancer recurrence. We will examine people's chests to look for evidence of fluid or changes in their lung exam. We can do an assessment of their extremities. If someone has swelling in one side and not the other, that can be something that can be concerning that we would want to work up further. But because ovarian cancer has a tendency to come back in the abdominal cavity, a lot of people who are ultimately diagnosed with recurrence have normal physical exams because the cancer comes back in a place that we can't feel it or reach on a physical exam. We end up finding it on imaging studies. I'm getting some questions about how common it is to have cancer recur in the brain. That's rare. We do see it with ovarian cancer. I don't know the numbers, but I can find them and submit them to OCRA to add to the recording of this video. But it's very uncommon to have ovarian cancer metastasize to the brain. If someone has neurologic symptoms like weakness on one side or sometimes a deficit in movement on one side, then we might do a scan of their head to make sure that we're not missing metastases outside of the chest, abdomen, and pelvis. The other tool that we have is a tumor marker CA-125, which is not a good screening tool for ovarian cancer for initial diagnosis, but it can be helpful in patients who have elevations in their CA-125 at the time of diagnosis. If we see that CA-125 is high at diagnosis and then it comes down with treatment and then it stays low and then it starts to go up again, it might be a reason to get a scan to take a look and see if there's any evidence of recurrence. What's tricky for me about CA-125 is it feels like each person has their own thermostat. I have seen some people who have a very subtle change in their CA-125 and we find evidence of recurrence on imaging study, and other people who have radical changes and there's very little change on their scan. So it's almost like it's more or less sensitive in an individual person. And this has been seen in studies that suggest that doubling of a CA-125 level, even if it's within the normal range, is worth following up on for someone whose CA-125 may tend to run low or for whom those subtle changes might be important. And then we rely on imaging studies to help us find cancer recurrence in areas that we can't access on physical exam because of the location, and to confirm recurrence or to assess for recurrence in the setting of new symptoms or a rise in the CA-125 tumor marker. I think most people use CT scans to look for evidence of cancer recurrence, but sometimes people might use a PET-CT scan, which provides additional information about the metabolic activity of a particular site. And then occasionally, if we're not sure if this is associated with a previous cancer diagnosis, people might undergo a biopsy to get tissue to determine whether the site of recurrence looks like the original tumor, or to confirm that this is indeed the ovarian cancer. And more recently, sometimes we will try to get biopsies if we want more information about the tumor at the time of recurrence for molecular testing or for participation in a clinical trial if that's available. Okay, so we'll talk about treatment options now. I'm going to change direction a little bit, and then we'll talk about some of the newer emerging treatment options, and then we'll talk about clinical trials. And so just to set the scene, the way we think about treatment for recurrent disease is primarily based on how someone's performance status is and how they're feeling at the time of recurrence. And it's also informed by what kinds of side effects they might have had with a previous treatment. And so the goal of treatment in the setting of recurrence is to prolong someone's treatment-free survival and overall survival, and also to make sure that we're not compromising their quality of life with the treatment regimen that we're considering. And so there are a lot of options for recurrent disease treatment, and those include surgery, chemotherapy. We'll talk about some targeted therapeutics. We can talk about hormone therapy. Radiation therapy is not used as commonly in ovarian cancer just because it tends to come back not in one specific site, but it can occasionally be used. As I said, we'll talk about clinical trials. We'll also talk about observation and best supportive care as considerations for people with recurrent disease. Surgery, as you know, is a mainstay of primary treatment for ovarian cancer. We work very hard to try to remove all visible disease as a goal of initial cytoreductive or debulking surgery, because we think that that makes the chemotherapy work better, and because optimal debulking has been associated with better overall survival. And it's one of those prognostic factors that we think we might have some control over, or might be modifiable, whereas we can't really change someone's age or her genetics or some of the other prognostic factors associated with ovarian cancer. And there is evidence that in certain cases, surgery can be helpful with the treatment of recurrent disease. And that is fairly person-specific, but seems to work best in people who have lower volume of recurrent disease and recurrences that are located in places that are accessible surgically. It also seems to be more effective in people who have what's called platinum-sensitive disease, which means they had a longer time since their last chemotherapy before finding evidence of recurrence, and people who are healthy enough to tolerate surgery. And so in some cases, people might undergo a secondary debulking, although this is very much dependent on her health and on what other treatment options might be available for her. Chemotherapy, I would say, is the primary approach to treatment for recurrent ovarian cancer. And most people do respond to chemotherapy when they have recurrences. And there are clinical factors that can help us set expectations about the likelihood of response. The tumor type and the size and the number of disease sites can be informative, as well as the type of cancer. Whether someone has clear cell cancer or serous cancer can shape our expectations about the efficacy of chemo in the recurrent setting. But I think the most helpful piece of information is how long it's been since her last chemotherapy, and specifically how long the platinum-free interval has been. Because we know that cancers that are very responsive, meaning they shrink in response to platinum-based chemotherapy, are more likely to respond to chemotherapy again, and especially if it's been more than 6 months since the last time someone was treated with a platinum agent. And so that's what's called platinum sensitive, if someone's gone longer than 6 months since her last platinum treatment without evidence of recurrence. And platinum resistant disease is disease that comes back within 6 months of a platinum-based chemotherapy regimen. Sometimes we see what's called platinum refractory disease, which means that the cancer might progress while somebody's getting a platinum agent. And those tend to be more challenging tumors to treat with chemotherapy. And usually we won't circle back to a platinum-based agent if someone's tumor has demonstrated that it can grow despite treatment with one of those. Oh, and sorry, I forgot this slide was coming next, but here are the definitions of platinum sensitive and platinum resistant and platinum refractory based on the time of treatment-free interval since the last platinum agent. And so you can see that in someone who has platinum-sensitive disease, the typical recommended treatment includes a platinum drug again, usually with another chemotherapeutic, sometimes in addition to another, sometimes a third drug. But in platinum-resistant disease, we don't typically use platinum agents again, and we'll rely on other chemotherapeutic options such as Doxil, Taxol, Gemzar, topotecan, or clinical trials. And then the same thing with platinum-refractory disease. We don't typically use platinum agents again if the cancer has grown through treatment with a platinum agent. And so here is a table showing some of the landmark trials of treatments that have been tested in people with platinum-sensitive recurrent ovarian cancer. And you can see that there's a high response rate to second-line, we call it second-line chemotherapy. And these trials are ordered by year. They get more recent as you get towards the bottom of the table, and you can see that the response rates are increasing over time. And so we are seeing better and better outcomes in response to treatment for recurrent disease as these chemotherapy regimens are updated, as well as improvements in supportive care with our ability to treat side effects associated with chemotherapy. And so what's highlighted in red here is the response rate. And you can see that it can be as high as almost 80% in the recurrent setting, which is usually what we expect in the frontline setting as well. And so we expect that most people with platinum-sensitive disease will have benefit from chemo for the treatment of recurrent disease. And you can see the progression-free survival, which is the time from start of treatment for recurrent disease until the likelihood of another recurrence, has also increased over time in patients with platinum-sensitive disease. When we see people whose cancer has recurred within 6 months of platinum-based treatment, the expectations are a little bit more limited. And this is a list of some of the chemotherapeutics that we use in the setting of platinum-resistant disease. And you can see the expected response rates are lower than they are in the setting of platinum-sensitive disease. And the expected benefit of chemotherapy is also lower in the setting of platinum-resistant disease. Although there have been some new regimens introduced, specifically some of the antibody-drug conjugates that we'll talk about in a little bit, that have shown higher response rates in platinum-resistant disease recently. So there's some renewed hope that we'll have alternative treatment strategies to offer people now. But you can see that the response rate is lower, the progression-free survival is lower, and typically our choice of agent has to do with what kinds of side effects are expected with a particular drug and what kinds of side effects someone might have experienced with prior treatment. For example, if someone had neuropathy from Taxol during frontline treatment, we probably wouldn't recommend Taxol as a second-line agent, just with concerns that we would exacerbate symptoms or the patient would have recurrence of the neuropathy that would be dose limiting. There are also several targeted agents that are available for the treatment of recurrent ovarian cancer, and some of these have been around for quite a long time and others are newer and emerging. There are several advantages to a targeted approach to treatment, and we use the term targeted agent a little bit broadly, but what we mean is something that we hope will impact tumor cells and have less impact on surrounding normal healthy cells. And so the anticipated advantages are that the toxicity profile is likely to be different than cytotoxic therapy, chemotherapy, and hopefully more limited because of the targeted approach to treatment. And we hope that these agents may be active in chemotherapy-resistant disease since they have different mechanisms of action. And often the way that they've been identified as targeted agents are through an analysis of the mechanism of action. So we may have a better idea of how they work and can apply them more precisely than some of the old-fashioned chemotherapy regimens. And so examples of targeted agents include Avastin. The other name for Avastin is bevacizumab. This is an antibody that's been developed to block new blood vessel growth. It binds to a specific target expressed by the cells that line the blood vessels and some of the tumor cells as well. And it's been shown to have a very high response rate in ovarian cancer in both platinum-sensitive and platinum-resistant disease. It's used as maintenance therapy, as we spoke about earlier, and it can also be used in combination with chemotherapy for recurrent disease, and sometimes a single agent treatment, but typically is used in combination with another drug. The biggest success story, I would say, in ovarian cancer treatment over the last 5 years has been the introduction of PARP inhibitors, which are oral drugs that specifically target a DNA repair pathway to inhibit the ability of tumor cells to repair themselves in response to chemotherapy or as they're dividing. And these are especially effective in people who have BRCA1 or BRCA2 gene mutations, either hereditary gene mutations or mutations in the tumor itself, because those BRCA gene mutations also impact DNA repair. And so the combination of the PARP inhibitor with that deficiency in DNA repair results in a highly lethal situation for the tumor cells and results in tumor clearance and long-term disease control in some patients. And then I've mentioned antibody drug conjugates. We'll talk about them in more detail, but this is a strategy to use the portion of an antibody molecule that's very specific for a protein to drive chemotherapy molecules specifically to a tumor site. And so this is a way to deliver cytotoxic therapy, but hopefully only to the places where people have disease. And that should also limit the toxicity associated with wider exposure to the drug and increase the efficacy of the drug by making sure that it gets to where it needs to go. And so this is some of the data about PARP inhibitors. These are older clinical trials, but you can see that these are survival curves showing progression-free survival by percentage of people on the y-axis and time on the x-axis. And the PARP inhibitor treated group is the darker line in both of these. And this first one is in people who have a germline BRCA mutation. You can see that there's a marked improvement in progression-free survival in patients who were receiving a PARP inhibitor for maintenance therapy who had a BRCA1 gene mutation. And that's indicated by the higher proportion of people who have gone without evidence of progression over time. But you can also see that there's a benefit that was observed in patients who did not have a BRCA mutation. And so there seems to be additional effects of PARP inhibitors that might benefit people who either have evidence of defects in DNA repair in their tumors or alternate mechanisms of action of the PARP inhibitor. And so these have been more widely used in people with ovarian cancer over the last several years. I'm going to take a break and answer some of these questions because they're coming in really fast. And so I'll see if I can go through them real quick, and then we'll talk some more about antibody drug conjugates. Oh man, holy smokes, there's a lot of questions. Okay, let's see. So there's a question about how long PARP inhibitors can stay in your system after you stop taking it, and how long do you benefit from PARP inhibitors? And so some of the examples, by the way, of PARP inhibitors are Lynparza. The other name of that is olaparib, niraparib. There's a couple of different drugs. I don't know, I'm sorry, I should know this, what the half-life of the PARP inhibitor is, but the actual drug is out of your system within a couple of days. And the benefit that people have from it depends a lot on their tumor, but we don't think that the drug is continuing to be active after they stop taking it. We think that the primary benefit is while they're still on it, which is why people are kept on it for long periods of time as maintenance therapy. There's a question about how long to be on Avastin, and that also varies, but typically when I treat people with Avastin, I keep them on the drug until there's evidence of progression or until they have side effects that limit our ability to continue the Avastin. The way Avastin works is it blocks new blood vessel growth into the tumors, and that prevents the tumor from being able to grow bigger because it can't recruit blood vessels to provide nutrients and oxygen. And so I think of it as a way of sort of holding the disease burden steady, not letting it get bigger. And we know in experimental models anyway, that when you withdraw that pressure, that treatment, sometimes you see an outgrowth of disease. And so I tend to keep people on Avastin for a long time because it's overall well tolerated. It doesn't make people feel as sick as some of the other cytotoxic agents. And I hope that that continued pressure will keep their disease at bay. Is there an average time before someone becomes platinum resistant? No, it really varies a lot person to person. Experience tells us that platinum drugs stop working for most people at some point. And so some people will be able to have frontline platinum-based chemotherapy, usually with carboplatin and Taxol, and then they might get a platinum doublet for recurrent disease with carboplatin and Doxil or carboplatin and Taxol, depending on their situation. And sometimes people can have platinum-sensitive disease for quite a long time and be eligible for platinum again. One of the complications is that people can develop hypersensitivity to platinum drugs, and so they may not be able to tolerate the drug although their disease might be sensitive to it, the patient might develop a hypersensitivity. And so that limits our ability to continue to give platinum. But the time to platinum resistance varies quite a lot from person to person. And so that, to answer some of these questions about how many times you can have platinum, really dictates how often we can use it and how long we can continue to use it. So I'm going to, and yes, this presentation will be available to you all. So I'm going to move back to antibody drug conjugates, and then I'll circle back to some of the questions again. So this is a diagram of an antibody drug conjugate. I've been pointing to my screen over here, realizing you're not seeing my arrow, but this up here is antibody drug conjugate. So antibodies are the proteins that your body makes to fight infection, and they're remarkable because they're very specific, and they're shaped like a Y, like this, with the triangle part of the Y is the part that recognizes the target. And what's happened is the specificity of these proteins have been leveraged for drug delivery with these antibody drug conjugates, so that they're designed to use that part of the antibody that recognizes a particular target and then link it to a chemotherapy drug so that the antibody will go to the target and bring the chemotherapy with it. And that way we think that we're delivering chemotherapy directly to the tumor sites and hopefully not to everywhere else in your body the same way that other drugs work, especially because some of these chemotherapeutics are called prodrugs, which means that they're not active until they get to the site of the tumor, and then they're converted by the cells to be a toxic agent, so that they're primarily able to kill cells at the site of the tumor. And there have been recent successes using this approach in ovarian cancer, and specifically in platinum-resistant ovarian cancer. But some of the caveats are that the drug is not expected to be as effective in people who don't express the target. And that makes sense, since the whole point of this is to drive the chemotherapy directly to the tumor site. So if your tumor doesn't express the target that's recognized by the antibody fragment, then you're less likely to have the drug specifically delivered to the tumor and activated at the tumor site. As I said, the goal is to enhance the anti-tumor effects while limiting chemotherapy toxicity, and hopefully to limit these off-target effects, although there are some new toxicities that have been discovered in the process of bringing these agents to the clinic. In particular, some of the targets may be expressed in normal tissue that aren't usually areas that we look to for toxicity. And one of them, I'm sorry, it's really noisy in my office. Let me just tell these people next door, please be quiet.
Well, I really think
I'm giving a national webinar and you guys be quiet. Thanks. Sorry, everyone. I put a sign on my door, but nobody read my sign. So there was just a lot of conversation going on outside the door. Apologies. Anyway, so as I was saying, these antibody drug conjugates are typically restricted to people who express the target of the antibody. And there have been some unusual off-target toxicities associated with them, because it turns out that some of the targets that have been used for ovarian cancer may be expressed in other tissue types. And one example is the folate receptor alpha, which is a target of this drug called mirvetuximab, which can be expressed sometimes in the eye and can lead to some ocular toxicity associated with treatment. And that's why people who are being treated with this new drug, mirvetuximab, have been asked to see an ophthalmologist during their treatment. And they put compresses, cool compresses on their eyes to restrict flow to the eyes to limit the likelihood of toxicities that have been observed in some of the clinical trials. Some of the other antibody drug conjugates that are being developed in ovarian cancer, all of them have names that are impossible to pronounce. Is this one that's targeting NaPi2b, and it's called upifitamab. And the clinical trials use this. There's a trial called UpNext to develop this product for treatment of ovarian cancer. And then there's some drugs that have been tested in other tumor types, specifically in breast cancer, that have been adapted now to ovarian cancer, targeting different proteins like the HER2 protein, which may be expressed by some ovarian cancers. And this cartoon down here is illustrating how this, in this case, this folate receptor alpha drug is working, that it binds to the target on the tumor cells and gets internalized in the tumor cell. And then once it's internalized, the drug is activated and can kill the tumor cell. And that requirement for activation, once it's internalized, keeps it from being cytotoxic at other places in the body. Okay. I'm going to switch gears a little bit and we'll talk about immune therapy. I feel like I need to say that as of right now, there are not immune therapeutics that are specifically approved for ovarian cancer, but there's a a strong rationale for using immune therapy in ovarian cancer, and there are a lot of clinical trials that are testing different types of immune therapy for ovarian cancer. So we'll talk about them, and I'm happy to answer questions about them towards the end. What's different about immune therapy compared to chemotherapy is that chemotherapy is targeting the tumor cell and trying to kill the tumor cell, whereas immune therapy is targeting the healthy immune cells and trying to help them work better in their ability to control cancer growth. So it's either trying to help T cells, which are the killer immune cells, better recognize cancer cells and kill them, or it's trying to remove some of the impediments to immune function in the tumor microenvironment so that the immune system can control disease growth. And ideally, it's trying to teach the immune system to recognize cancer cells so that if there is a recurrence, the immune system can be activated to, again, control disease progression. Some of the advantages of this approach include the fact that the toxicity profile is quite different than the toxicities associated with chemotherapy. Because it's not a cytotoxic drug, it doesn't tend to have the same side effects like diarrhea and hair loss and decreases in blood counts that chemotherapy has. And as I said, the hope, the holy grail is that this will have a long-term benefit if it can educate the immune system to recognize the cancer in the future. As I mentioned, these are currently available for people with ovarian cancer only through clinical trials, with the exception of some specific tumor agnostic approvals, which means there are approvals for some kinds of immune therapy based on the molecular profile of the cancer. And so that applies to people with ovarian cancer who might have their disease associated with Lynch syndrome or microsatellite instability, which can be tested in the tumor and through genetic testing. Examples of immune therapy include cancer vaccines, and there have been several that have been tested in ovarian cancer. T-cell therapy, which has been in the popular press and has been very successful in other tumor types, which is taking a person's own T cells and modifying them to make them better able to recognize tumors. And then these immune checkpoint inhibitors that have been game-changing in many solid tumors, and there have been multiple clinical trials trying to figure out how to adapt these to benefit people with ovarian cancer. And these are the ones that you hear about. The brand name is Keytruda for pembrolizumab, but they all have these, this should say durvalumab, the B fell off, but they all have these names that end in AB, and that stands for antibody, since that's the structure of the drug. So this is how I talk about immune therapy with medical students, so bear with me, it's just 2 slides, 3 slides. But this is how your body's immune system works. An antigen-presenting cell, this APC over here, surveys your body and picks up any dead cells or abnormal invaders or infectious products. And then the antigen-presenting cell presents these molecules to T cells to educate the T cells to recognize the intruder or the infection or whatever the target is. And as the T cells are activated, they become cytotoxic and they can go out and kill the target, in this case, hopefully a tumor cell. And so the way I talk to students about this is that the antigen-presenting cells are like the informers. This is like a middle school analogy. The antigen-presenting cells provide the information to the T cells that the T cells need to do their job. And then the T cells go out and find the target and eliminate it. And I can't bring myself to label this little kid tumor, but you get the idea about this interaction. And so then the goal of immune therapy is either to help the antigen-presenting cells provide more information or to have more antigen-presenting cells able to provide the information needed to educate the T cells, so more informers. And an example of that is a tumor vaccine that can activate the antigen-presenting cells and provide them with information about the tumor that they can pass along. Or T-cell therapy, which is either arming the T cells or expanding the population of T cells that are able to recognize and control tumor cells. And so all of these approaches have been tested in ovarian cancer. To date, these haven't moved forward to late-stage clinical trials except for some of the immune checkpoint inhibitors. And we all look forward to being able to bring these to the clinic for ovarian cancer because there's a strong rationale for there being spontaneous immune control of ovarian cancer and the opportunity to control the disease with immune therapy. And so just to summarize, the goals of the immune therapy are to elicit or boost an anti-tumor immune response, to induce this memory response for long-term protection. And then there's a lot of interest right now in combining this with chemotherapy to try to figure out ways that it might be most effective, particularly for the treatment of ovarian cancer. Okay, There are a whole lot of questions. So if it's okay, I'm going to keep going, and then we'll circle back and go through all of the questions towards the end here. But I have a slide next about hormone therapy. This is an approach to treatment that uses either hormones like progesterone agents or drugs that block hormone production like aromatase inhibitors for the treatment of ovarian cancer. And these have been used in multiple different kinds of epithelial tumors, as well as in some of the stromal tumors. And they've been particularly effective in low-grade serous cancers. There's a clinical trial ongoing now to test whether these are so effective that people might be able to skip the chemotherapy for low-grade tumors and go directly to hormone therapy. That remains to be seen with the results of this trial, but there's definitely evidence that low-grade tumors in particular can benefit from hormone therapy. Examples include tamoxifen, fulvestrant, and as I mentioned, the aromatase inhibitors. And you can see that the response rates are not particularly high, but the disease control rates may be higher, meaning that sometimes these drugs can stabilize someone's tumor for several months or long periods of time. And that can be helpful, not just because it controls tumor growth, but because the toxicity associated with these drugs tends to be much less than the toxicity associated with chemotherapy drugs. And so sometimes this can be helpful to provide someone with a break from chemotherapy regimens and to keep her disease under control for a period to allow her body to recover from chemotherapy that she might have received before or from ongoing side effects associated with chemo. And then lastly, we mentioned radiation therapy. This is not commonly used for ovarian cancer. It's challenging to use radiation for ovarian cancer because the tumor tends to recur in widely disseminated places, particularly in the peritoneal cavity. And the toxicity associated with radiation over large areas of the body and over the peritoneal cavity with everything that's in it, like the bowel and the bladder, can be very challenging. But ovarian cancer is very responsive to radiation treatment. And so sometimes if someone has an isolated recurrence, they might consider radiation as a treatment option. And sometimes if someone has, for example, symptomatic disease in her lung that's one or two sites, that can be treated with radiation with targeted treatment to that particular site. And then lastly, I try to train myself to always talk about what would happen if we didn't start treatment when we diagnose recurrence. And in an effort to try to be complete about options for a person and about expectations about response to treatment and the impact on someone's quality of life. And so I bring up observation in this context because I just wanted to bring up a clinical trial that was done now several years ago in Europe that really impacted my thinking about treatment for recurrent disease and that I wanted to share with you. So as I mentioned before, we know that removing tumor at the time of diagnosis and removing all visible tumor is associated with better long-term outcomes. And so we work really hard to get rid of all of the cancer. And in some cases, we'll do surgery to remove tumor again. And so there's a lot of evidence that treating cancer while it's small is helpful. And so people have extrapolated from that to think that we should treat recurrent disease as soon as we find it before the tumor becomes larger or symptomatic. And this makes sense because if the cancer continues to grow and causes symptoms like a bowel obstruction, that might limit our ability to treat someone because it impacts her ability to stay healthy and strong enough to tolerate treatment. But this trial specifically asked that question about, well, should we start treatment as soon as we find evidence of recurrence, in this case within a rise in CA-125, or is it okay to wait until someone has evidence of recurrence on imaging or physical exam? And so to address this question of does earlier treatment specifically in response to CA-125 rise benefit people, this trial recruited patients with ovarian cancer and randomized them to know their CA-125 values or to be blinded to their CA-125 values, and their providers were also blinded. And so once someone had a doubling in her CA-125, she was assigned either to this group that was called the early treatment group, and they started chemotherapy based on this change in the CA-125, or they were assigned to this delayed treatment group where they were not told about the rise in CA-125, and treatment was only started once someone either developed symptoms or had evidence of disease on an imaging study. And then they compared these groups of people for treatment-free intervals and overall survival, as well as quality of life. And what was kind of surprising or frankly shocking was that there was no difference in overall survival in these two groups of patients. The people who started chemotherapy as soon as their CA-125 doubled did not live longer than people who waited to start chemotherapy until they had evidence of disease on exam or on imaging study. And importantly, the quality of life was diminished in the patients who started treatment early because they ended up having more chemotherapy regimens for recurrence during their lives and accumulated the toxicities associated with all of those treatments. And so this doesn't mean that you shouldn't treat a recurrence early. It only means that at least at the time that this was published, which is now more than 10 years ago, it didn't seem to improve long-term outcomes to treat early. And so that, to me, suggests that there's an opportunity to potentially delay treatment or to consider close follow-up with imaging in a person who has a rise in her CA-125 or early evidence of recurrence. And so lastly, I'll talk about clinical trials and what you might consider if you're thinking about enrolling in a clinical trial, and maybe some questions to ask as you're thinking about this. So in contrast to standard healthcare, clinical trials are designed to answer a question. And usually the question is, can we do better? Is there a better treatment available? Does this new treatment outperform what we have currently for people with recurrent disease? And so there's a goal of treating the individual who's enrolled in the trial, and also the goal of expanding our understanding and our options for treatment more broadly. And so some of the advantages of enrolling in a clinical trial are that there's quite a lot of oversight of the treatment and of the course of disease and response to treatment and toxicity of people who participate. All clinical trials have to be approved by institutional review boards, and some of the trials that are sponsored by national consortia are overseen by national institutional review boards that have requirements for the ethical conduct of trials and for oversight and for how the consent forms are worded and how information is provided to participants. All of these pieces of the trial are very carefully monitored. All trials require informed consent, and it's important to know this, that clinical research or participation in clinical research is entirely voluntary. And you should expect that anybody who's offering you a clinical trial will reassure you that if you choose not to participate in the trial, that they will still provide treatment for you and you will still be eligible for treatment outside of the clinical trial. Participation has to be voluntary and not coerced. And so there's an informed consent form that everybody has to sign to participate. And then in terms of the structure of the trial, there are some ways that trials are designed to try to help us answer the questions that the trials are asking that can be different than standard treatment. And the most, so some of the most different pieces are that people can be randomized to treatment. And in fact, they often are for later stage trials, which means that you don't get to pick which treatment arm you are receiving, and usually neither does your provider. And you may not even know which treatment arm you've been assigned to, and those are blinded trials, like the one we just talked about where the women didn't know that their CA-125 had doubled. That information was withheld as part of the clinical trial that they were participating in. And sometimes that can be challenging for people who are being treated, as well as I'll tell you as a provider. We sometimes try to figure out what arm somebody was assigned to based on side effects, or there's just this desire to know what's going on. But there are rules with the trials to allow unblinding in certain circumstances when it's necessary for someone's health care. But the blinding is to protect the data, to help us make sure that any benefit we attribute to a new treatment is really from the treatment and not from other factors that might influence someone's outcome. As you've heard, there are different phases of clinical trials. Phase 1 trials are trials that are designed to test a new regimen. It's usually a first-in-human trial. And the goals of this trial are to decide if a treatment is safe. And so the trial tends to be small, and the primary endpoint is typically toxicity. And this is important to know because when you're introducing a new treatment through a clinical trial, usually the way that it's done, particularly for cytotoxic agents, is to start with a dose that's lower than what is expected to ultimately be used to make sure that that's well tolerated. And if that's tolerated in the first, usually 3 people, sometimes 6 people who are treated. Then the next dose is tested, and then a higher dose until what's called the maximally tolerated dose is established. And so different people enrolled in a phase 1 trial might get different doses of the study drug depending on when they enroll and what kinds of toxicity have been observed in previous participants. Because these trials are small and because the goal is to assess toxicity, they are not randomized. Usually everybody gets the same treatment. And there's a lot of oversight and monitoring for evidence of toxicity, which means there's often a lot of blood draws to look for drug levels and changes in blood parameters that might be associated with toxicity. If something is determined to be safe, a new drug is determined to be safe, and a maximally tolerated dose is established, that agent might move into phase 2 trials, which are trials that are designed to look for evidence of efficacy. And so these, while phase 1 trials might enroll people with lots of different tumor types, phase 2 trials are usually focus on a particular cancer type to see if this drug or regimen is effective in people with that type of cancer. And so usually the dose that's established in phase 1 is carried through to phase 2, but there may be some additional adjustments and dose finding that is built into the trial. And phase 2 trials, depending on how large they are, might be controlled, meaning there might be 2 groups of patients, or they might be uncontrolled single-arm trials, which means everybody gets the experimental treatment. And also depending on the size and whether there's 2 treatment groups, they might be randomized or not randomized, depending on the goals of the trial. But if you're enrolling in a phase 2 trial, you will be given a new agent for which there's at least some information about toxicity and maybe even some early anecdotal evidence of efficacy. But at the point that something's being evaluated in a phase 2 trial, we usually don't have the data to tell you how effective we expect the drug to be, or to even know whether it's more effective than standard treatment. And then if there is evidence of efficacy in a phase 2 trial, agents can move on to a phase 3 trial. And these are the really big trials that are usually run across the country with hundreds of people participating. And these are trials where a promising agent is being tested against the currently available standard of care. So they're looking for what's called the therapeutic ratio, comparing the new drug to whatever we're using as part of standard of care. These are often randomized trials, and they may often be blinded trials. And typically what's tested is standard treatment versus standard treatment plus an additional drug, because it's not ethical to give someone just a placebo who has a cancer diagnosis. And so typically the way new agents are introduced are in conjunction with available drugs or as a combination regimen to see whether the addition of the third drug has added benefit in a group of patients. And then lastly, there's something called phase 4 trials, which is post-marketing surveillance, because sometimes once a drug becomes widely available, new side effects are observed when it's given as part of regular clinical practice. And this is tracked by the Food and Drug Administration, and sometimes can lead to changes in approvals for drugs or changes in recommendations about how a particular agent should be used. And so if you're thinking about participating in a clinical trial, I think it's important to understand the goals of the trial as you're considering this, so that you know what to expect from it and what kinds of benefits you might receive through your participation. In my own opinion, I feel like it's helpful to have trials available because it just provides me with more options to offer someone. And sometimes sometimes it can feel restricting to just have the 4 standard or 5 standard chemotherapy regimens available for platinum-resistant disease. And so having a trial that offers something new that may be effective for a patient is extremely helpful. Additional benefits, for example, for a phase 1 trial are that you will have access to the newest agents that are just being developed that have shown some promise and enough promise to move forward into clinical testing. The other advantages of a phase 1 trial are that they're not randomized and they're not blinded, as I mentioned. And since they're smaller studies, the results are expected to be available sooner than the larger trials. As far as disadvantages, this dose escalation strategy, at least for cytotoxic drugs, trying to establish the maximally tolerated dose, may mean that early participants get a lower dose that might not be as effective as a higher dose. And the primary outcome, as I said, is safety and tolerability, not efficacy. So we really don't get information about how effective this will be for a particular disease. You might get anecdotal data that it really helped a particular person, but usually these trial cohorts include people with lots of different tumor types, and so it's harder to understand what to expect for a particular disease type. And phase 1 trials may or may not be given with known active agents. So you might get a single drug or a single regimen that's entirely an experimental regimen in a phase 1 trial. And those would be important things to ask of your provider and ask of the people running the trial so that you understand the risks involved and the potential benefits of participating. In contrast, the phase 3 trial on the other end of the spectrum is testing something that's already made it through phase 1 and phase 2 and has shown some evidence of efficacy that's promising enough to invest in a huge national clinical trial, enrolling hundreds of patients. And so this is something that has clearly shown promise, and the design of the trial is such that you should expect that you're going to be getting typically standard of care chemotherapy plus the experimental agent. The challenges here is that these are often the trials that are randomized and may be blinded, and that can be sometimes difficult for people because you don't know which arm you're in or which treatment you're getting. And sometimes there's a placebo component. For example, you might get chemotherapy with carboplatin and Taxol plus a new drug, or carboplatin and Taxol plus a placebo. And if that second drug is continued as maintenance therapy, you might be coming in for treatment, just getting placebo for maintenance as part of that trial. And sometimes that can be, that uncertainty can be uncomfortable for people. The other issues about larger trials is since they're so large, it may take a while to get final results to know the outcomes of the trial that you participated in. So there's just different goals for the different phases of the trial that may impact your consideration about whether to participate and your expectations about what you might receive as part of your participation. As I said, I think there are additional benefits to clinical trial participation, which include oversight by not only your own provider, but a team of nurses and doctors and study personnel, both at the local level and at the national level for most of these trials. The clinical trials are all designed to expand options for treatment for people with ovarian cancer. And so there's a collective benefit to participating in clinical trials to advance the science, to improve options for people with this disease. And so there's a benefit to the individual, we hope, and also a benefit more broadly across society to advance our understanding. And that can influence someone's decision about whether to participate in a trial as well. And so here's a list of questions that you might consider if you're thinking about enrolling in a clinical trial. They go over what we've just talked about. What's the rationale for conducting the trial? What evidence is available to make this particular agent seem like it might be effective? What are the objectives of the trial? Are you studying toxicity? Are you studying efficacy? What phase of the trial? What phase is the trial, and how many participants are expected to be enrolled? It's important to understand the intervention and the schedule of the trial, because there may be additional tests like blood draws required to measure what's called the pharmacokinetics, how long the drug is in someone's system and what kinds of toxicities might be associated with that. It's very important to ask about possible risks and side effects, and sometimes those are known and sometimes those are not yet known. So for example, with a phase 1 study, there may be an idea about what kinds of side effects to look for, but since those are first in human trials, there is likely not a lot of information about side effects available at that point. Understanding the endpoints, as we spoke about, knowing whether the endpoint is toxicity or the endpoint is efficacy might influence your decision about participating. You may want to ask who's sponsoring the trial, and certainly what kind of contact information is available if you have concerns or have questions about your participation. And so lastly, this is my slide from last year, which happily has been updated because now antibody-drug conjugates are approved, or some of the antibody-drug conjugates have been approved for ovarian cancer. So it makes me happy to see that some of these emerging therapeutics are moving into the clinic and being available for patients outside of clinical trials. I told you that there are a lot of immune therapeutic strategies that are being tested in ovarian cancer. There are many, many active clinical trials testing different approaches to immune therapy in ovarian cancer. And there are many trials testing combination therapies, either combinations of immune therapy and chemotherapy or new targeted agents in combination with chemotherapy. And so there are a lot of new approaches to treatment that are under investigation, and I hope that there'll be even more updates for this slide the next time I present this talk. And so this is White Sands in New Mexico. In summary, there are many options available for the treatment of recurrent ovarian cancer. The decision about which treatment to consider has a lot to do with a person's previous experience on chemotherapy, what side effects she had with her previous regimens, what her general fitness level is, what her goals are, what the schedule of treatment is like, and how it might impact her quality of life. As I said, the overall treatment is to optimize the quality of life and prolong someone's survival. And it is, in my opinion, certainly worth considering what clinical trials might be available. And the Ovarian Cancer Research Alliance has resources to help connect you with clinical trials, either in your area or to screen for them nationally to see if there's something that you might want to participate in. And so I appreciate your coming to this webinar. I'm sorry about the interruption. I'm going to now, with the remaining time, try to work my way through some of these questions that have been coming in as I've been talking. And please, if I don't get to your question, it's not, it's just because there's a lot of them, but I'll do my best to work through them. So we were talking earlier about the PARP inhibitors. We talked about the Avastin. We talked about how long the PARP inhibitors might stay in your system. And we talked about the time to platinum resistance. And we talked about how many times can you have platinum depends typically on whether you develop hypersensitivity to the platinum. So here's a question about circulating tumor cells. So those are an area of active interest and investigation. And so circulating tumor cells or circulating tumor DNA use blood tests to find either individual tumor cells that might be in the circulation or evidence of tumor DNA that can be detected in the blood. And this has been used in the development of some emerging screening strategies that might be multi-disease screening strategies that are under investigation currently, not yet available for standard treatment. The data in ovarian cancer is a little bit more complicated. And has been evolving. But the idea is that if we could find circulating tumor DNA or circulating tumor cells, that might tell us about the likelihood of recurrence earlier, and it might give us information about the tumor burden, as well as giving us some information about genetic modifications that might have occurred in response to prior treatments that can be helpful in designing or making decisions about future treatment regimens. So many clinical trials are now collecting circulating tumor DNA or circulating tumor cells from people with ovarian cancer to try to determine whether those blood tests can either predict response to treatment or predict resistance to treatment earlier so that we can use that in treatment decisions moving forward. Someone's asking me about PARP inhibitors in non-BRCA, non-homologous recombination deficient patients after frontline treatment. This person says she was told it was not a robust response, but can help a bit. I think that's a good way to put it. We have seen that PARP inhibitors are not as effective in the absence of homologous recombination deficiency, which is a defect in double-stranded DNA repair that sensitizes cells to the effects of the PARP inhibitors. There have been clinical trials showing some benefit in those patients, and so there are indications for using PARP inhibitors regardless of someone's HRD status, but our expectation that it will control the disease is not as great as it would be in someone with a BRCA gene mutation or evidence of homologous recombination deficiency. There's a question about the danger of long-term use of PARP inhibitors, and this is an area of important investigation currently. So PARP inhibitors in most clinical trials were used for up to about 2 years as maintenance therapy. So people got chemotherapy and then they started the PARP inhibitor and they continued the PARP inhibitor for 2 years. I don't know how the 2-year time point was decided, but what we have in the clinic is that we know what people experience who are on PARP inhibitors for 2 years. Some people have been continued on PARP inhibitors longer than 2 years with evidence of benefit and ongoing disease control. And so now there have been publications describing people's experience on PARP inhibitors for a longer time, usually outside of the context of a clinical trial. It's called real world data, just reporting back, kind of like that phase 4 approach, reporting back about what is observed. There's a clinical trial that's working its way through the system to ask whether whether all of the benefit or most of the benefit of a PARP inhibitor might be achieved in the first year of treatment, and whether we can shorten the amount of time that somebody's exposed to PARP inhibitors. That's still an unresolved question, but the impetus for that is the concern that longer exposure to PARP inhibitors might increase someone's risk of toxicity associated with the PARP inhibitors, both sort of everyday low-grade bothersome toxicity like nausea or fatigue that can be associated with these drugs, as well as drops in people's blood counts, anemia, or low platelets, and the rare but serious risk of certain kinds of blood disorders. It's called myelodysplastic syndrome. It's kind of like a leukemia that can develop in response to PARP inhibitors. It's reported as rare in the clinical trials, but it's the concern is that longer exposure to the drug may impact someone's risk of something like that. And so I think the general clinical practice is to continue treatment with PARP inhibitors while it appears to be beneficial for a person, but the optimal amount of time to be on a PARP inhibitor is still an open question. Someone's asking if recurrence occurs after immune therapy, what types of treatment options are available? Immune therapy doesn't really limit your eligibility for other treatment options in any specific way. Because immune therapy is currently only available through clinical trials, a particular clinical trial may say that you can't enroll if you've already had immune therapy, if they're testing an immune therapy, so there may be rules like that. One of the interesting things about immune therapy in other tumor types is that there is evidence that people who have been treated with immune therapy in the past may benefit from it again in the future. And so it may be something that can be used again. Which is different than chemotherapy, where we think if a tumor has developed resistance to a particular drug, it might not be a good idea to use that drug again. The different ways that immune therapy works suggest that there may be different approaches to using it again in the future after somebody's been exposed to it once. But it doesn't exclude you from chemotherapy or from targeted therapy unless there are just clinical trial rules that require that. I apologize. There's a question about what is germline. So germline mutations are mutations that you inherit from your parents. So they're in all of your cells. And so people with germline BRCA mutations are people who have a hereditary defect in the BRCA1 or BRCA2 gene. And their tumor cells lose, so you have two copies of every gene. If you have a mutation in one of them and your tumor cells lose the other good copy, that can result in cancer development, and that's why the risk of cancer is higher in people who have the BRCA gene mutations. Sometimes those mutations develop in a cancer, and so that's why we've started testing tumors for what are called somatic mutations, which are mutations that are only in a particular cell. They aren't in all of your cells because they're not inherited. But those tumors that have somatic mutations might also respond quite well to PARP inhibitors, just like a tumor that had an inherited defect in the gene. There's a question about using ablation in recurrent disease. I think that means radiation therapy, although there's other ways to ablate tumors. Sometimes in the liver, people will talk about ablation. But for for radiation therapy, for example, if someone has a lung nodule, that might be something that could be targeted with radiation therapy. As I said, it's difficult to deliver radiation therapy to the abdomen because of the toxicity to the organs that are there. And also because most of the time ovarian cancer isn't just in one spot in the abdomen, it tends to be widely disseminated. And so it's harder to target with a local treatment like radiation therapy. Oh, my apologies. Somebody's asking if everything I just said applies to primary peritoneal cancer. Yes. So primary peritoneal cancer looks just like ovarian cancer under the microscope. The cells are the same types of cells. They're typically serous, high-grade serous ovarian cancers or tubal cancers. And so when we talk about this disease, and when there are clinical trials designed, they usually will say ovarian tubal or primary peritoneal cancer because that's considered to be the same cancer. And whether it's considered ovarian or primary peritoneal usually depends a lot on how much disease is on the ovary, but the cancer itself is equivalent under the microscope. Okay. Oh, thank you. Somebody answered my question. Oh, thank you. Look at all these answers. Thank you, everybody. I appreciate that. If you haven't had a recurrence, will there be a medication in the future to prevent a recurrence? I hope so. That's kind of how PARP inhibitors have been used for maintenance therapy, and even Avastin. because those maintenance treatments are used often in the situation where someone's had frontline chemotherapy and surgery, so she might not have any detectable disease. And they're used to prolong the time before a recurrence is found. So to prolong the progression-free interval or progression-free survival. If someone gets ocular side effects on the folate receptor antagonist, will they go away after stopping the drug? I think so. So that's why we try to catch them early and have people under the care of ophthalmologists. I will say that, at least personally, it's very uncomfortable for me to manage ocular toxicities because I don't treat ocular toxicities and have not learned how to do that. And it's kind of a learning process for all of us to manage these things as they come up with the new regimens. And so we rely very heavily on collaborations with ophthalmologists to monitor for evidence of injury to the eye and to manage any toxicity that occurs. There's a question about pembrolizumab and why is it only recommended for up to 2 years. So pembrolizumab is an immune checkpoint inhibitor. It's one of the drugs that's been game-changing in other solid tumors, but has not yet been approved for ovarian cancer, except in the subset of people who might have microsatellite unstable tumors. And the question is about why the 2-year period of treatment is used. And that is just like the PARP inhibitors, it has to do with how the clinical trials were designed. And so a lot of these clinical trials are designed to test pembrolizumab for 2 years. And so we have data about what to expect from 2 years of treatment, but we don't have as much information about what to expect after that. And so just like PARP inhibitors, there's accumulating data from people with other tumor types about, potential benefit of ongoing treatment, or interestingly, with this kind of treatment, ongoing benefit after stopping treatment. Because if we can educate the immune system to recognize tumor and activate it, then there can be continued benefit after stopping taking the drug. I am skipping these questions about people's individual tumor care because it's hard for me to comment on your treatment without more context and without examining you. So I'm going to keep going and talk about the more general questions. There's a question about the efficacy of HIPEC, and so that's also an active area of investigation, particularly for people who have chemotherapy prior to their surgery. There are some very compelling evidence indicating that, HIPEC is hyperthermic intraperitoneal chemotherapy. So it's delivering chemotherapy directly to the abdominal cavity during surgery, and it's heated. So the idea is that the heat helps the drug penetrate into the tumor, and that there's added benefit to getting that at the time of debulking surgery. And this has been demonstrated in several studies and is now being investigated through some large phase 3 trials here in the United States, with evidence of longer progression-free survival, in some cases with the use of the heated intraperitoneal chemotherapy. There's a question about natural supplements. The challenge about natural supplement, there are several challenges, at least in my opinion, about using natural supplements. One of them is that they're not regulated in the same way by the Food and Drug Administration. So things like dose and content are not strictly regulated the way drugs are. And so it's harder to know what someone's getting and what dose to use. The other challenge for me, at least, is that I have been brought up in a system that looks for clinical trial data as evidence of efficacy. And so there aren't the same kinds of clinical trials or the same kinds of evidence that we use for the treatments that we've just talked about available for most of the natural supplements that are available. There are some, and there are, with increasing interest in natural supplements, there are clinical trials that have been developed. Things like high-dose vitamin C has been evaluated in some early phase clinical trials, and some other supplements have been investigated. And so I think that you'll see more of those coming up through clinical trials and more information available about them. But it's harder for me to make recommendations about them because the kind of evidence that I rely on is not usually available for these supplements. Can you have the NCT number for the clinical trials testing? I'm sorry, I don't have the NCT numbers, but if you go to clinical, this is asking about cancer vaccines. If you go to clinicaltrials.gov and you put in ovarian cancer and vaccines, you can see some vaccine studies that are available for ovarian cancer. And there are several different approaches to cancer vaccines that have been tested in ovarian cancer. Somebody says that she's participated in 2 clinical trials and does not regret it. I'm really happy that you don't regret it. I think that sometimes there can be some really nice opportunities available through trials that aren't available through standard treatment. Oh, holy smokes. And here's somebody who I treated more than 10 years ago. Thanks for reaching out. That's really wonderful to hear that you're here. What percentage of ovarian cancer does not reoccur? Oh, man. So, and it's already been, thank you all. You're answering your own questions. I really appreciate it. So yes, the answer here is approximately 20%. I think that's about right, because we usually say that about 80% of people respond to frontline treatment, and about 80% of those people usually recur. It's tricky because we think that the lower risk of recurrence is in people with earlier stage disease at diagnosis. But we know that some types of ovarian cancer that might be slower growing or more indolent tumors, like mucinous tumors, tend to be diagnosed at earlier stages. And so there may be differences in the types of tumors that are found at stage 1 that contribute to the lower risk of recurrence. And our ability to screen for ovarian cancer has not resulted in a test like the PAP test that can find it early reliably, as you know. Thanks. There's all these nice comments. Thank you all. There's a question about letrozole, but it references a previous question, and I don't know which one to reference back to. So if you don't mind to put your letrozole question back in, I'm working my way down towards the bottom of these questions. Do I know anyone studying recurrent endometrioid ovarian adenocarcinoma of the ovary? There is a trial that has recently been proposed that was specifically focusing on endometrioid adenocarcinoma because of a mutation that might be more prevalent in those kinds of tumors, but it has not been launched yet or approved. A lot of times endometrioid ovarian cancer is lumped together with serous ovarian cancer as a kind of epithelial tumor that may be high grade and may respond to the same types of treatment. And so that it's not as common to see a trial specifically for endometrioid ovarian cancer. The PARG inhibitors that are soon to be released by the FDA within a month in a phase 2 trial. I don't have specific information about PARG inhibitors. These are drugs that affect a different part of the DNA repair pathway. They're sort of associated with PARP inhibitors, but they target a different part of that signaling pathway. And they have been developed and tested in ovarian cancer. I don't have an update about where they are in the process. If they're in a phase 2 trial, it may be a little while yet because they'll need to be confirmed in a phase 3 trial. Although there have been a couple of examples of exceptional responses in phase 2 trials that sometimes accelerate approvals, but I don't have a good answer for that question. Oh, my apologies. There's a question about hormone therapy. It's not that it's only used in low-grade cancer. It's that it is especially effective in low-grade tumors. So when we talk about the grade of a cancer, that's talking about what the cells look like. So the stage says whether it's gone outside of the ovary and how far, what locations it's gone to in someone's body. The grade is talking about what the cells look like under the microscope and how abnormal or atypical they look. So high-grade cells are more atypical and low-grade cells are less atypical. And because low-grade cancers tend to have a lower proliferative rate, they may be less sensitive to chemotherapy because chemotherapy is killing the rapidly dividing cells. So low-grade cancers have been more difficult to treat with chemotherapy. But fortunately, it looks like they can be treated with hormone therapy, and the effectiveness of the hormone therapy is such that there's a clinical trial, a phase 3 clinical trial currently testing whether hormone therapy by itself may be as effective as giving someone chemotherapy and then switching to hormone therapy. So we do sometimes treat high-grade serous cancers with hormone therapy, and we do sometimes test it for the expression of estrogen receptor. And if it does express estrogen receptor or progesterone receptor, we feel like those might be good candidates or better candidates for hormone therapy. So the answer is yes, there's a role. And then you all answered that. Thank you so much. Oh, and thanks, Sarah. Sarah DeFeo's on. She put the link for the Clinical Trials Navigator in the chat, and so that's available to all of you. And I apologize, I guess I had an outdated web page, but it's here, ocra.careboxhealth.com. And that's a wonderful resource for finding clinical trials and making sure people know what's available to them. Do I see HIPEC being used at some point for stage 1 disease? I don't know. The outcomes for people with stage 1 disease tend to be so good that there's even a question about how much chemotherapy to offer someone with stage 1 disease. And so I don't know what the role for HIPEC might be in those early stage cancers. The other reason is related to what we talked about before, which is that sometimes the kinds of cancer that we find at stage 1 are different than the kinds of cancers that are more commonly found with evidence of metastasis at diagnosis. And so I think that will influence the use of HIPEC. It is used for mucinous tumors, and those are some of the cancers that we tend to find early, but the outcomes for stage 1 cancers tend to be quite good. And so I don't know what the role of HIPEC might be. Any studies of combination radiation therapy and immune therapy or chemotherapy for ovarian cancer? Yes, so there are several. In other tumor types other than ovarian cancer, there is some evidence that radiation might work well together with immune therapy. Since we don't tend to use radiation therapy as much in ovarian cancer, that hasn't been an approach that's been advanced in ovarian cancer the same way. But certainly chemotherapy has been tested in combination with immune therapy. And the thinking is that chemotherapy can kill tumor cells in a way that exposes the antigens, the markers of the cells, in a way that the immune system can then pick them up and recognize the cancer cells better. And so if you can kill some of the cancer cells with the chemotherapy and at the same time activate the immune system, that might be a really powerful way to educate the immune system to recognize tumor cells. And so those approaches have been tested in multiple different combinations: frontline chemotherapy with immune therapy, recurrent disease with chemotherapy followed by a vaccine, for example. Lots of different combinations looking for the right one that's going to be most effective in ovarian cancer. Besides Avastin, what else can be used as maintenance for BRCA deficient and HRD negative patients? Avastin is the more common one. Sometimes people will use PARP inhibitors, but you're right that those are less often used in the absence of a homologous recombination deficiency. There are some clinical trials that have used treatments as maintenance therapy, and if those show benefit, those may be something that's brought forward. But the most commonly used maintenance therapies, as you mentioned, are PARP inhibitors and Avastin in the frontline setting. Thanks, Sarah. We're going to have to wrap up. Oh, sorry. Okay, I can't see the clock at the same time. So it looks like Sarah DeFeo is telling me that I'm running over time. So I think this will be available to everyone. And thank you all so much for your questions. I really appreciate it. I'm sorry again for the interruption. And I wish you all the best with the remainder of the conference.